e-delivery of EMR for a value-based healthcare. To handle the session, we have Dr. Geetha Govindan, IEEE Senior Member and Scientist at G Computer Division from Sree Chitra Tirunal Institute for Medical Sciences and Technology with us. To welcome the honored speaker and other delegates, I invite Engineer CM Varughese, Chairperson, IEEE Education Society Kerala Chapter, to take up the platform. Over to you, sir.
Good evening, one and all. Distinguished guest and speaker of the day, Dr. Geetha Govindan, IEEE Education Society Founder Chair, Professor Muhammed Kasim, and advisor Dr. Kesavaswamy, sir, and EC members and the members of EMB, and our secretary Jithin, student team, and all those present here for this seminar. IEEE Education Society is conducting this program along with the EMB. EdSoc, or Education Society, is a new society chapter, just 4 months old. So this is the third program we had. Out of that, two were in medical, including this one. And in between, we had a very grand ceremony of our inauguration, and several programs are running by our students. Even though it is a new chapter, it's growing very fast to any activities, and it's going to be one of the best chapters in the coming years. And we have very senior professional members along with us to guide, to take us forward, bring in many programs. And today's program, of course, good evening, Kuru sir. Today's program, of course, on the very novel, good subject for the time, during this COVID, e-delivery of EMB. So when we hear about EMB, especially e-delivery, we think it about our old times where, we get a prescription from a doctor which cannot be read, only a pharmacist can read it. But now we go to a doctor, we can see he's in front of a computer. So all test reports, all records, his prescription, everything is in the computer. So things has changed. But still for a patient, it's not accessible for him, the records. If you have to move from one hospital to the other hospital with the old records, it is difficult. I'm not sure this EMB, what is adopted now, will address these solutions. Let us hear from experts, and also in the EHR, that is e-health record also. Hope it will be very beneficial for all of us, and wishing a very nice delivery of the subject. And my duty is to welcome the distinguished guests of the day. So this is our Dr. Geetha Govindan will be, of course, introduced after this. Welcome, madam, to this webinar. So we are really delighted to you have for this evening. And we have Coach Varughese sir from the EMB. I think Dr. Manoj also is there. So I welcome both of you to this meeting. So I do welcome our founder chair, our advisor, our student team, our secretary, all to this evening session. And let us hear the wonderful speech. And by that I conclude, and over to next.
Okay, thank you, sir. Now, I invite Engineer Jithin Krishnan, Secretary, IEEE Education Society Kerala Chapter, to give a detailed introduction about our esteemed speaker, Dr. Geetha Govindan, and invite her to take the session.
Jithin, you are on mute in case you are speaking.
Yes, sir. So, good evening, all. So, good evening, Gauri sir, then Varughese sir, Kasim sir, Geetha madam. So, it's really a very privilege for me to introduce a very senior colleague of mine from my own institute. So, for a function like this, and Dr. Geetha ma'am. So he's currently heading the computer division and a scientist G also. So it's a very having a person having a 30+ years of service and still continuing very energetically heading the computer division. And she is actually the pillar and backbone of almost all kind of electronic records and kind of networking, everything related to computer happening in the institute. It's not easy to manage 3 institutes together. Actually, it's consists of 3 separate institutes clubbed to a single name. So she single-handedly handles the 3 institutes. This is geographically also different places. And coming to education, she completed this education in BTech from University of Kerala way back in '86. Then her master's in computer science from Central University Hyderabad in '88. Then she had her PhD in bioinformatics from University of Kerala in 2014 and all. And from professional side, she has been working ever since her BTech or MTech days. She has been with the NIC Planning Commission, then a long career of 30 years in Chitra and still continuing. She has been a recipient of so many awards from the institute, including MS Wilson Awards for outstanding contributions. Then, as I said, since she's heading the computer division, and now institute is a very peculiar institute having 3 different types of institutions in a single umbrella. So she's involved in each and everything in our institute, mainly what management of information services in the total systems, networking systems, GEM, electronic medical records, so many things and so many things. And in between, she is a very active member, IEEE, I think, senior member, and also she is a member of ACM also. Then whatever things, so I don't know, so many things. If you take a hospital or a research center or a public health center, there are so many things there. So that so many labs are there, directors there. So many things are there.
Okay,
Ma'am,
Jithin.
it will take some time. Fine.
Okay,
There
thank
are so
you.
many things actually. So I'm just making people understand that the things being done here is that much big actually. And so I'm too proud to welcome you, ma'am, to this session.
Yeah.
And ma'am, over to you, ma'am, please.
Yeah, thank you, Jithin. So let me start and thank you for all the good words. I think I will start the session and okay, sir, Kasim sir, I will start.
Yeah, ma'am, please.
Yeah, okay. So I'm just starting my presentation. I'm sharing the screen. Is it all visible? Yeah. Visible? Can you reply?
Not yet.
Not yet visible?
Yeah.
I've shared the screen. You have shared the screen. Share the entire screen.
Hello, please help.
Entire screen I have shared.
Yes, ma'am. Please click on entire screen and there will be a dialog box opening. How to, at the top, you can see a dialog box opening.
It wants to share the content. Share. Yeah.
Yes, share.
Now come. It has come?
Yeah.
Yes, ma'am.
Yes, come. Nice.
Yeah.
Yes.
So, I'm just, my topic is e-delivery of EMR for a value-based healthcare, a strategic framework I have added, and I'm Geetha, a senior member number 015782777. So my topic I am splitting into 3, that is e-delivery and EMR, and then I will come to what is value-based healthcare. So in the e-delivery of public services, like everybody knows from the name, that it is a World Bank project. I don't know how many of you will know that it is a World Bank project, which is costing around $150 million, and policy-based budget supported to assist Government of India in 2011-12 period.
So that is the basic behind the implementation of National E-Governance Plan, NEGP. So this fund is used for creating the e-governance for all states, all through India. So a government-wide initiative it was to make all government services accessible to the common man, that is government to citizen, G2C, as well as government to government. And why it is being done by Government of India is to ensure efficiency, transparency, and reliability of services at affordable cost. I'm audible, no? I'm audible? Hello?
Yes, ma'am, you're audible.
Yes, you are audible.
Okay. So this is e-delivery I'm saying for all services. In that, health also includes. So health is a major part in e-delivery. So Government of India wants e-delivery to be used in healthcare also. So this NEGP governance gives a lot of importance for healthcare. So that explains the e-delivery of my topic part. Now I am coming to electronic medical records. Everybody knows what is electronic medical records. It's a digital version of the traditional paper-based medical record. And basically, it is within a single facility such as doctor's office or a provider's place or a clinic. And personal health record, we also maintain personal health record. It's again some documentation for individual, maintained by individual. But EHR, when it comes to EHR, it's a health record. It's for that individual that is shared among multiple facilities and agencies. Suppose you fall sick in, you have a record in one place, and if you fall sick in another place, how that EHR will give you the data in that place. So that is electronic health record. So these are the three terms. And what Government of India has done is, we will think that Government of India, we had not done it, but they have made a standard electronic health record standards for India in 2013, and it's a very big document which is made with a big committee, even with the Confederation of Industry, EIA, they were all part of it, and they had formed the framework for the, as I said, Government of India standard for EHR. And in 2016, they had revised the standard, and it is available in the Ministry of Health and Family Welfare, Department of Health and Family Welfare site. So we have the basic standards defined, and of course, it is the copy from the standards used for EHR is definitely a copy which is internationally used. The standard, we have not made our own thing, but it is the international standards which is suggested for using EMR for creating the medical record. So why the standards were defined? It is basically for the interoperability. It is the ability of the computer systems or software to exchange and make use of the information, and consistent representation of interoperability in information models, standardized vocabulary, standardized nomenclature and codes to describe clinical problems, procedures, medication, allergies, etc. Participation and adoption of standards by EMR vendors and stakeholders, and implementation cost should be low. So this is basic reason is interoperability. Like it should be compatible to exchange the information. It should be understandable in each location. And the recommended health standards for India, I have just with the 40 minutes time, I thought I will cover only 7 of them. The first is the UID, which everybody knows. It's a health identifier. It is an Aadhaar number. And second is the pharmacological therapeutical classification, which is BIMS or SIMS for the medicines. And we have WHO drug directory. We're very sorry to say that India has not released a drug directory for our purpose. So we have to take the data, and some of them we have to add it manually. And LOINC is the logic observation identifier name codes. It is for clinical laboratory observation. So these are the standards defined for each area, and it is maintained by Regenstrief Institute, that is in USA. And SNOMED CT is called Systemized Nomenclature of Medicine. It is the clinical term, the clinical terminology to capture the problem list, allergies, diagnosis, procedures, etc. And the site is mentioned here. And next comes the ICD coding. ICD-10 is the coding used for disease classification, and it is a convergence of ICD and standard CT. And next comes health level 7, HL7 messaging, which is used for sending the messages between the machines. It's a data interchange protocol for healthcare computer application that simplifies the ability of different vendor supplied systems to interconnect. And DICOM, of course, the medical major part is the medical images, and it is under DICOM. It has to be under DICOM standards. So DICOM is digital imaging communication in medicine. It is a standard to define the connectivity and communication between medical imaging devices. So this 7 standards covers the data formed in the medical record, formed as the medical record. So I am just talking how we can get the electronic medical record using these standards. So I'm going to the next slide. There is Government of India says we have to, when you go electronically, we have to have some security standards also. So they are telling even access control to computer should be biometric. That we cannot implement it everywhere, but the manual says it should be biometric login, and we should have access privileges, automatic log off, audit log, integrity, authentication, encryption. So this data should be very much secure. Like it should not, one person's medical records should not be visible to the other person. Otherwise, that HIPAA, we have to implement HIPAA, they are telling, but that is all not, we are not able to do it on flow, but these are the security standards they are suggesting. And the minimum data set, even to form a medical record, they're telling either whole, with the field name and length, etc., is mentioned in the standard manual, where they're telling that minimum data, that they call it minimum data set, should have an UHID, Aadhaar number if it is not there, an alternate number to identify the patient, name, date of birth, gender, address, allergy, emergency contact, past history, height, weight, blood group, diagnosis, treatment plan, etc. So these are so important. Like many places, they won't note the height and weight. They're telling it's so important to record the height, weight, etc. And medical name, they said it should have the strength, dose, and image data. The patient should be given the image in DICOM format, and various lab reports should have the impression. That means the final conclusion should be available. Clinical note should have a diagnosis, investigation, advice reports, diagnosis after investigation, advice, follow-up, observation, etc. So the standard says even provides sample clinical summary note, how one person should write the note. That also is given very clearly in the standard of Government of India. So I'm saying the data collection, it can occur at various stages. The moment you enroll, from the moment you enter the hospital, the data collection starts. The stages are screening, examination, diagnosis, treatment. So by the time the treatment comes, we have a lot of medical records generated. So I'm just showing what all standards can be used at various stages. For example, enrollment, that is integration through Aadhaar is necessary, or through direct data entry, we can get the enrollment. So now most of the people have mobile. So just mobile number and Aadhaar and name and date of birth and gender. This might be enough to enroll a patient. And the screening clinical reports against requests. So the clinical reports, this can be totally automated. So it can be done through a LOINC and HL7 messaging. There is no human intervention required, or automatically machine can send the report. So this is through LOINC and HL7. And examination, again, it can be done through SNOMED CT, LOINC and HL7. Diagnosis against coding has to be done using ICD-10, and the exchange of data through HL7. And treatment is again clinical summary. So the next one, I thought I will just, the 6 standards, I will explain Lowing, HL7, ICDs, NOMAD CT, DICOM and PACS. And I want to stress how automation can help, how we can get the data without manual interference. So the first one I'm saying Lowing is the standard given for laboratory test results. So LOINC is called Logical Observation Identifier Names and Codes. And it is something like a barcode for measurement and reports for clinics and laboratory. It is divided into 4 categories: lab, clinical, attachments, and surveys. So I'm just saying about the lab part only. And it is maintained by Indiana University. This Regenstrief Institute is under Indiana University. And we won't believe it started in 1994. And so these standards are well defined. And the same standard we have taken. And it is mainly for microbiology, biochemistry, and chemical labs. So I'm just showing how the Lowing messaging comes. So the moment a computer, so when doctor says, you please do the blood test of hemoglobin or whatever, the sample is taken and the workstation, the sample identity is entered and it orders the equipment, the medical equipment which is doing the blood test. It gives the order and for that particular test hemoglobin, and the Lowing codes will be sent to the machine, and machine understands and the result is sent back to the workstation. So there is no manual entry required. The moment the result is ready, it is available in the system. So this is, otherwise we used to do manually, take the result from the equipment and type it again into the workstation. That is not required. The direct messaging, we can get the lab result. So in the Lowing has got field types called components, what is measured, evaluated, or observed. The component first one is what is measured. Example, if it is hemoglobin, that is the component. Kind of property, characteristics of what is measured, that is whether it is length, mass, volume, timestamp, and so on. Time aspect is the interval of time over which the observation or measurement was made, and system is the specimen, whether it is urine, blood, etc. And type of scale is the scale measure. It can be quantitative, original, or nominal. So I'm just showing the sample Lowing codes. So I'm saying here, this is the code, 83022, means it's a body weight of the patient, and it is measured in length, point of time, it is that instant of time, and the sample is the patient only, and it is a quantitative thing. So this is how it is coded. And so the body weight, I can just mention 8302-2, 76 kg, like that. So there's a patient hemoglobin level. The message going into the machine is 7187 hemoglobin MCNC PT BLB QL. What is that? Component is hemoglobin and the property of measurement is MCNC. This is the mass concentration method, is the type of test to be done, and point of time, and the system, the sample is blood, and quantitative is this, should be the scale. So the moment the result is ready, the machine sends back 718-7 hemoglobin value. So you are immediately getting the result into the system. So I'm just showing a sample message where there are 3 sites here on the left side, and I'm showing it on how it is corrected using Lowing in the right side. Suppose here one person writes sys-BB for systolic BP. Another person writes SBP. Another person writes BP. So how this computer can interpret it is very difficult, whether it is sys-BP or SBP or BP. All are systolic BP is the meaning they wanted, but somebody is writing sys-BP, somebody is writing SBP and BP. So how to change this? You just replace with that code here, and 84798, it is replaced and sent to 3 locations. So immediately the machine will know it is the systolic BP, and the value 132 or whatever. The LN shows that it's a Lowing code, and so it gets converted back by the machine very correctly. So it's a universal coding. So we know now you move any part of the world, the machine is sending the correct information and they can read it. So when it comes to EHR, so the code, if the lab results are sent in this code, everywhere it will be read in the same way. And the next, why the advantages? It is for improved communication, zero chance of human error, automatic report transfer, immediate availability of the result. So you don't have to wait. Immediately the machine will give you the result. And next comes the HL7. So how we have to send the thing? This is through a health level 7 messaging system. It's founded as an international standard development organization in 1987 to promote communication between hospital data systems. This stated a goal of creating a platform independent method of moving data between different systems, develop grammar for messaging and standard vocabulary, ANSI standard for clinical interoperability, and the versions, as years go, it started from 1987, they keep on changing new releases, but there is always backward compatibility. And the site is hl7.org. So I'm just showing here a sample message HL7, how it looks. So the HL7 message goes into different segments, and segments are divided into different fields, and fields are divided into different components. So what is the final thing? We should have an HL7 control server, the mirth and other things like that, which can work as a control server, which can be connected to a database server. So all the requests entered in by the provider meaning the hospital, the registration, after registration, one blood request is entered. Immediately it goes as an HL7 message. The controller server receives it and sends to the laboratory machines, and the equipment, after the result is ready, again sends it back as HL7, and the database server will get updated. So this final display will be from the database server. So you will get the result from the database server. So this HL7 messaging, it's very, it's the standard for interoperability. Like even if the equipment change, you don't have to recode the systems. Like it is very independent. Like it doesn't depend on a machine, equipment type, and all that. So it is a text type of messaging which has been used for so many years. So I'm just showing a sample HL7 messaging. The messages are a series of segments, and each message defines segment are applicable, the order must occur in, what is required, optional, etc. And there are separation for that cap and symbols are used for separating the messages, fields and components. And the field may occur in multiple segments, and definition of field is saying regardless of segment in which it occurs. So it's a text, plain text actually. And I can show you some of the messages samples. For example, send vaccination history. The message will start with VXU. VXU, when the machine understands, it immediately knows the vaccination history is to be sent. Or send demographic update or transfer. ADT messages, it's definitely admission, discharges, transfer of the patient, those related messages comes under ADT. Acknowledgement comes under ACK. So these are codes which are used in HL7. And I'm just to understand, I'm just giving a sample HL7 message which has got a MSH is the header of the message, and PID is the patient identity. So I'm going on sending the text message. The patient identity, I know that the patient name is somewhere here. His address is here. So this message goes to the next place in this manner. And the next server which picks up the thing will decode and put it in the database. So this is the way HL7 message works. And we are using HL7 version 2. It's more than enough for the coding purpose. So this is how the IL1, the medicine also is being sent. These message headers will define what the message is. So, and the messaging process, why it is called HL7, is because it works in our OSI model. It works in the application layer. It is the 7th layer. So that is why it is called a health level 7. HL is health level. H and L is. So since it is working on the application layer, it is called HL7. So I'm just to understand it better way, I am creating a center here, and center and receiver, and sender prepares the data for transport, and it goes from the application layer to the transport layer, and the receiver parses the data and process the data and prepares the response, and the response is prepared, and response comes back through the transport layer and parses the response. And 6th one is the processing the response, and the sender does the action accordingly. So as soon as a trigger is received, this sequence of events takes place and the data gets updated. Once the receiver receives the request, he will collect the information, and that with the answer, it comes back to the center. So this HL7 has got syntax and semantics. That is why it needs a parsing also. So it needs both syntax and semantics. So it is working as a parser. And now I am moving to the ICD coding. So when you finally, there are so many diseases, codes. So instead of writing in a different way, like one doctor, for example, for the blood pressure, like I said, BP, they might write somewhere like systolic BP. So the diagnosis will not be uniform. So internationally, ICD, international coding for diseases, has to be used as a standard. So anything, any diagnosis, we have to code it using the ICD-10. ICD-10 has got 3 to 7 characters, and there are about 68,000 codes. And this is again, they keep on updating, but it has got a compatibility. Now ICD-11 is also available. But you won't believe this ICD coding was started in 1893. It was done by the people for the recording the cause of death. And it was adapted by the International Statistical Institute in 1893. We are yet to do the coding of ICD-10 in all hospitals. But I'm saying how much they had evolved, ICD-6, ICD-7, ICD-10, now ICD-11 has come, which is integrated with SNOMED CT also. So this is one of the way of coding. So everything, now manual entry, it is all, the diagnosis has to be selected from the ICD-10 list. So that anywhere if the record goes, with the ICD-10 coding, the diagnosis can be made out. And I am showing here the sample. Again, it is numeric codes only. 163.40 means cerebral infarction. Procedure code, it is excision of liver. This OFB0ZX means excision of liver. And the approach also is mentioned. So these are the sample codes. The ICD codes, few samples are like this. And I'm just saying an example of how the doctor's version and the patient version is get converted into ICD coding. This is a small example where Mrs. Findlay, one lady, while cooking, she hit the kitchen board or kitchen cupboard, and she became unconscious. And it took long. She was taken to the hospital, and the doctor, what they have told, and she used to get headache in between, and that history. If you write like this, it is a big story. Writing into the pages and pages. But when you code in ICD-10, it is this much only. That is ICD-10 when you code. She had a concussion with loss of consciousness for 30 minutes. Its code is S06.0X1A. And acute post-traumatic headache and intracerebral, it is G44.31. And it even is struck by a falling object that has got an ICD code. It is W20.8XXA. P93.G3 is the activity when this happened when she was doing the cooking. So my mouse is going on. So that was she was doing the cooking. So that code is given as Y93, and the place of occurrence where it happened, where the incident happened, it happened in the house. The code is Y92.0.10. So this explains the whole history of what they were telling written in the text. This 7 codes will explain the whole thing. So if a message is sent like this, immediately the doctor will know what happened. So during cooking, something fallen on her, and she had got the traumatic headache. She got the cervicalgia, like that. So this is the benefit of the ICD coding. And this next comes the SNOMED CT. SNOMED CT is actually systemized nomenclature of medical clinical terms, and this is a quality healthcare request effective communication. Effective communication means what? It needs a common language and a common structure for humans and computers. So SNOMED CT allows clinical data to be recorded in a human and computer recognized way. And SNOMED CT is a national common vocabulary of clinical phrases for electronic systems, and it is maintained by International Health Terminology Standards Development Organization. And again, it is there from 1965. These standards are available. And it again consists of main 4 primary code components: concept codes, which are the numeric codes which are getting stored, and descriptions, relationships, reference sets. So I will just show how this SNOMED CT can be used. So this picture is from the SNOMED CT site only, and it has and this site shows, this box shows the body shows see this body structure, clinical finding, environment, geographical location, event. So all these hierarchies, all are defined, like quantifier value, recorded artifact, specimen. So it has got hierarchies, attributes, and identifiers, descriptions, and relationships. So I'll just instead of thing, I will show you how it is. One simple example. So bacterial pneumonia, doctor says now you have bacterial pneumonia. So what is it? It is ESA. It's an acyclic graph. So it shows bacterial pneumonia is a 2 options are there for the doctor. It is a bacterial lower respiratory infection, or it is a infective pneumonia. If the doctor goes for infective pneumonia, there are 2 options: infectious disease of the lung or pneumonia. So pneumonia means it's a lung consolidation. So ESA, it is like it is lung consolidation is a disorder of the lung. It is a disorder of thorax. It is a disorder of trunk. It's a disorder by body side. It's a disease. So when we code infective pneumonia, and this finally the code will, and the relationship what is selected will give you a SNOMED CT code. So very simple way you can code the whole discharge summaries or the observations of the made by the doctor. So I am again giving another sample here. Here it's an open fracture of the neck femur. So it is an open fracture of neck femur. It is a fracture of neck femur. So these are it has got it's different names. It can have different synonyms also. It's all the descriptions are given in this clinical SNOMED CT. We can choose that, and internally the links, the relationships and attributes get stored. So no need for more explanation. It's all inside. It is well connected, and the way you select the thing, internally the code will get stored. For example, here pain in calf. pain in calf, it is a pain in lower limb. It is a lower limb finding, and it is a pain. So it will finally has an attribute, which is where is the site. So the site, when you select, it can be calf structure or it can be lower limb structure. So coding this much is enough to make out that the patient had a lower limb pain in calf, which is at the lower limb. So this is how the code is coming. And so the three major database tables are, we have to store the concept. It is a concept ID with fully specified names and description, which is having the concept ID and description status, description type, and the relationship we have to record. So these four database has to be made. It is all free. The CDAC is providing the service. It is all freely available, no charges. You have to make the database ready, and the program has to be made in such a manner to select the concept ID from the list of table, so that the doctors will go into the correct SNOMED CT terms. They will store they won't be seeing the internal coding. For them, the description is shown, like here they will see the name as fracture neck or femur, like that, but internally the code is getting stored. So these are the three major tables. I'm saying here, I'm given an example here. For example, appendicectomy, the code is 80146002. It is done as a priority because the patient was sick or something. It was done as an emergency. Again, priority emergency has got an SNOMED CT code. And using the device, what type of surgery done? Laparoscope. So these are the codes which get selected and get stored internally. So the text we can generate, patient has undergone appendicectomy with under emergency using the device laparoscope. This is how the SNOMED CT clinical terms are used. So as a summary from what I spoke, ICD-10 can be used for diagnosis, for history, medications and all. LOI can be used for clinical lab tests. SNOMED CT can be used for all purposes. This is now SNOMED CT and ICD-10 are connected. So the moment you code using SNOMED CT, diagnosis automatically gets coded as ICD-10. And now the major next part is the images. So images, we know that all are DICOM. The images, most of the machines, MRI, CT are all DICOM. So the images itself has a header having the patient name, type of the media, whether it is CT, MRI, image dimensions, medical body will have the medical reports, audio recording, images. So the sample CT and MRI image will be like this. The image will have the data along with it. That's why it's called a DICOM. So this text lines along with the image will help you to identify the patient name, type of the media, etc. So it is called DICOM, Digital Imaging and Communication in Medicine. So all the imaging systems now comes under DICOM standard only. So this DICOM again, we have to talk with the machine. So again, it is happening at the application layer, and this is the ISO reference OSI model, where these messages works in the application layer and transport layer. It comes to the packets, comes to the transport layer, goes to the next to the network, to the next place, and again comes back to the application entity. We call it, whether it is a CT or MRI or this, and it can be a workstation where the message goes and comes back. And DICOM service, we call this as a DICOM service. It is actually a very big topic, all a very big topic, and I just put some few pictures. And we call it service object pairs, where the patient information is coded as an IOD, and it is, and I'm just giving a picture here. So this is a workstation. Suppose a patient comes for MRI, the computer immediately sends the request to the CT scanner that so-and-so patient is coming for the CT. So the CT scanner screen will automatically display the name of the patient. That work list automatically comes on the CT. So there is no way the mistake, the error is, human error is very less. Like the work list, the request is shown, and the message as a message to the scanner, and scanner displays the patient name, and it matches, it checks for a handshake whether everything is perfect, correct or thing. And once the study starts, it confirms, and the image, once the study is complete, it will send the image to against this request. So there is one-to-one mapping always, and there is always a handshake, so that no way like manual errors, like sending a different person's image to another person, that will never happen here. If it is tightly integrated with HL7 and DICOM, then there are less chance for any errors. So this is the advantage for images. And finally, every image, we have to show all the images in the network. That is, we call it as a PACS. PACS means it's for storage and distribution of images and information. And P here covers all pictures, images, and reports. Almost all, like ultrasound, everything are DICOM now. And non-DICOM units are also there, like ECG and Holter. Those things are having images, but they are not DICOM, but they have reports in PDF formats. Again, that can be sent as message. And A is archive, online, near online or offline. C is communication, networking, transfer protocols. S is system components and architecture. So that is this is the final PACS connectivity. We are generating the data. Yes, DICOM or non-DICOM or images from outside, like somebody will bring image from outside, ultrasound image in a CD. Everything you can read and put it in the PACS. It's a storage actually. It is a big storage of storing all DICOM and non-DICOM images, and that images can be read into the network. So again, it is automated. There is no manual. The machines are talking themselves. So there is no human, very little, like very little. They have to just verify whether everything is happening correctly or not. Any error is there, or 99.9 there won't be any error. The machine just communicates. The advantage with this HL7, these messages are all HL7 thing. That the moment you change the MRI here, tomorrow you are bringing another equipment. There is no need. The system will work by its own, because it's all communication is through HL7 messaging. There's no need. Only thing, the IP or the machine name only addition is required. Otherwise, the machine will go on sending images. Now I am coming to the second topic. I've talked how the EMR is formed. So these are the ways in which you are generating the medical records electronically. And now there are methods to e-deliver. Now, how do you e-deliver the thing to the patient? That is only way now we have is the patient portal, which can be an app or a web-based portal where you are authenticating the patient through a login, a hospital number or password, and patients can download the reports. And some places where we can through SMS, it's difficult to include all the details, so we can probably send link as SMS. Like SMS will on clicking the link, it opens up the prescription or lab result if they have the internet connection in the mobile. So that is one way of delivering electronically the health reports. These are the only two methods. Other things are all manual paper delivery only. Electronically, we can deliver and reach patient only through patient portal and or through an SMS link. And finally, the aim of the electronic medical records is the patient can view their own records, interoperability, record once, read many times, and a common standard of vocabulary. This is our aim. But I wanted to show next one is I'm coming to the topic, what is value-based healthcare. So in our, if you look at our situation, the primary care, like in the front end, maybe having all automation, like we have the registration desk and all that. But when you go internally to the secondary care, like IP admission, we are still on the papers. Like most of the hospitals still are on the paper, but they are scanning or they might be coding it and keeping it, or to some extent it might be they might be using SNOMED and ICD to code and keep it. And so I'm just saying, coming to the third part, what is the value-based healthcare? Is the improvement in health outcomes for the cost of achieving that improvement. What is the cost for the treatment and what is the outcome? So that comparison is the value-based healthcare. So for that, we have to workflow redesign we have to do, where we have to eliminate all non-value added work. Like we are saying it should be value-based, so to eliminate all non-value work. Like, so for example, some tests may not be required. So we have to eliminate that. We have to automate as manual task as possible, delegate the work to trained or non-physician staff. Suppose some work, for example, taking ECG or something, like we don't need a very high-tech person. Now the machines are very much high-tech, so we need a trained non-physician staff only required, which will bring down the cost. And we have to incorporate new workflows as soon as more new type of machines comes. We have to have new workflows. And we have to teach the patient. The patients also to be aware. They have to be made aware that your reports are generated electronically and it is available. So there we have to teach them. We have to make them aware about the changes. And how to optimize for a value-based healthcare. And EMR enhancements can be like health management reminders to patients and medical professionals. For example, we can prevent a diabetic patient from progressing to kidney failure or neuropathy. That means the EMR has the data, and somehow we have to send the reminder to the patient to make them do the test and make them knowing their situation, what is your sugar level. So we have to teach them and make the system should remind them about the due, the test is due, something like that. So we can, that way we can avoid the patient becoming into a neuropathic patient or kidney failure patient. So this preventive care can be enhanced. And data feedback can be studied. We can have a feedback session with the patients, and that can be add on as a value. And improving the preventive care is the major thing, which finally will save money. And a new workflow, for example, if suppose a migraine patient comes, just like giving a medicine and sending him off, we can have the provider can arrange a relaxation training. So these are the value adding to the healthcare. Or we can suppose a chemo cancer patient needs a chemo. Why not the provider give arrange a transport? Because otherwise they may not come and do at the required period of time. They will not finish it. So these are value adding. Like we for Onam sales, they are giving someone free for one. We can also have EMR enhancements. But why? How can we do? We can do only if we have the data properly. If we have the data, we can have all these enhancements and can it can add the value. And why? Now I'm going to the next value. I told about the value, but in a different angle, I wanted to inform. See why healthcare spending is growing. It's growing like anything. Like as years go, it's going to increase only. So the government of India and all other governments, even US, they have gone into a one step ahead and saying what is the real value for the healthcare. So the points I'm quoting is from the Harvard Business School. And they said the current way of healthcare is fee for service. Like we are paying initially and taking the service. Quality is an afterthought. We never bother about the quality. For example, we go and take X-ray. Maybe X-ray will be having the chain the person was wearing. They won't have even asked them to remove the chain. And the X-ray will be having even that image. And the transparency regarding the quality and total cost of care is lacking. No easy connection between benefit and payment. Lack of private-public partnership with hospitals. These are the major problems. And the quality is an afterthought. Is a very important. We don't bother what is the quality for the amount we paid. What is the thing we got back? So that is a major lacking. And so we need a value-based healthcare. There is no doubt we need a value-based healthcare. And then coming to that, the framework what we are suggesting is that choose the service, that provider, meaning the hospital, should choose the service based on excellence in patient value. Identify a segment of patients whose health and related circumstances create a consistent set of needs. So they can choose the area of their excellence. More integrated units form an interdisciplinary team of caregivers to design and deliver solution. So with the team, if there is a team is making the board we call medical board, or for each patient, if there is a team of interdisciplinary caregivers, then it will give more value and more partnership with alliance. We won't all the same provider won't be able to do. So you can have some partnership with other organizations, so that they will take care of some part of it. And they can have to expand only high performance practices to measure health outcome and cost care for each patient. For each patient, what is the outcome and cost to be measured? And this can be done only if the doctors are given an education on value-based healthcare in medical school itself. So this is possible only when the doctors also are given a training from the MBBS degree onwards. So we will be surprised. This hardware company, Dell is the topmost hardware company, but they are running a medical school in Austin, in Texas, to incorporate educational value-based healthcare. That medical school is the topmost school now, and they are creating a value-based. They're giving the training from the initial period onwards how to create a value-based healthcare. Like if the patient comes for I told no, if they come for a migraine, they will be treated not only for migraine, but they'll be again sent for some therapy, psychological counseling, like that. So that the decision is taken by a board. It is not one person, but it's a group team of caregivers. So this is how they explain the value-based thing. And the principle of value-based delivery is the value of the patient is the major thing. It is the capability, comfort, and calm of the patient. How capable he is to do his own work, how comfort the patient is, how independent the patient is. This is how the value is measured. And to deliver value, healthcare must be reorganized around medical conditions over the full cycle of care. It is not just one admission and discharge, but after few months of review also. That also should be added to find how much the value he got for this treatment. Value is driven by provider experience, scale, and learning at medical condition level. Value must be universally measured. It is a standard universal because the diseases are common. It's a universal diseases, so it is universally measured. And information technology has to be there. It has to enable restructuring of care delivery and measuring results. That is, we need an integrated EMR, no doubt. We need a data collection at each point, and then only we can check the value where we have gone bad. And the reimbursement should be aligned with the value and reward innovation. This is the reimbursement of treatment is to be based on the value. So I am sure who all are participated in this talk, I think almost 60% will be having a insurance scheme for health. So now I'm coming to the point. The last point is how value-based schemes we have in India. We'll be wondering how we have implemented this value-based reimbursement in India. This slide I'm saying, see here, the sentence is reimbursement should be aligned with the value and reward innovation. So I am just coming to my last slide, and this is I'm saying various insurance schemes, Hridyam, RBSK, Government Insurance Scheme, Ayushman Bharat. I just want to inform the Government of India have already done this Ayushman Bharat, which is based on a value-based health scheme, meaning the patient is not paying, it is reimbursement to the provider. The provider has to update the data. The moment the patient comes in, like for FIR, immediately the information has to be updated into the Aishman Bharat site, and they will assess after 1 day, 2 day, what is the reports, and they make a list of how they will assess. The provider will assess, and the hospital provider is reimbursed for the service made up to some standard. Like if suppose the patient got discharged within a day, then maybe that case will get reimbursed fully. But if the patient is delayed for another 3 days or 4 days, it may not get the full reimbursement amount. So they have put a Government of India has put a capping on all the procedures. So if the provider, meaning the hospital, does the service within the capped amount. Suppose, for example, an appendicectomy is 1,000 rupees, and if the hospital provider does it in 800 rupees, 200 rupees is a gain for the hospital provider. So that's how the value-based system has been already introduced. We will be wondering how in India situation, in a place like India with so many hospitals, and but we were able to have a value-based system. Similarly, is the Hridyam scheme in Kerala. Hridyam is a scheme where it is done for congenital surgeries. Congenital surgery is for the patient for the small children born with heart disorders. So the Hridyam, we cannot get a small child operated in Kerala without registering in Hridyam. So the moment one hospital says this child has got a heart problem and needs a surgery, the hospitals are advised to register in Hridyam. So Hridyam is again an insurance, acting as an insurance agent, where they are collecting the data. So now they have all the data from Kerala, which all hospitals are doing so and so type of surgeries. So seeing the type of the diagnosis, the Hridyam itself tells the patient, you go to this place, okay, you go to Amrita or you go to Sree Chitra. So that Hridyam plays a role there, and they get the reimbursement. The institute, that provider will get the reimbursement according to the value only. So if the operation gone successfully, or if the operation is done with minimum minimum lab test and all that, they might be refunded more. Similarly, is the RBSK scheme, which is being used now. That also a very strict scheme where they are going too much on the value. So the unnecessary tests and all they won't get. That provider will not be reimbursed much. So this most of the, I think they are telling by 2024, almost all will be under this type of insurance. So this is these schemes are by Government of India. The advisors are PricewaterhouseCoopers, and the site is giving more information on all the schemes of Aishman Bharat, RBSK and all. So I am concluding by saying the Aristotle code, quality is not an act, it is a habit. It has to be built from childhood, and accountability is required. If you want a value-based healthcare, we have to have an accountability. Each entry, each request is accountable. Why it is made? Is this really required or not? And that accountability breeds the responsibility. There's a responsibility which Stephen Covey says. So this is this accountability and the quality is really required to have a value-based scheme, value-based healthcare scheme. And my references are, these are the references, and mainly Harvard Business School and PwC India and Wikipedia. Other standards are all standards. All the sites gives the details. And that's all my talk. I don't know I'm clear or not. And just back to you.
Thank you, ma'am.
Yeah.
That was really an informative session. You even included the sample codes and examples in the presentation, and they were really helpful. And it was also good to know about the value-based healthcare delivery.
Yeah. Okay.
Madam, one
And thanks a
question.
lot
One
for giving
small
us a deep view
question.
of the topic.
One small question. Is it so happen in future with so much of automated data, the diagnosis and the prescription can be or will be automated?
Yeah, diagnosis doctor has to make. Like he will be prompted. Like normal CT I showed, it's really helpful. He will not miss out. Like each type of surgery, it's a big consortium of doctors who are making it, and so it helps him. He will be pointed to the correct direction. So his diagnosis can be made very very pinpoint. He can make even the surgical thing. They will prompt what type of procedure because it's all well defined now. It's like a dictionary. So the thing is, I told no, the way of thinking has to change. That's what I said. You cannot suddenly change it. The medical schools, and I don't know how much time it will take, but I'm sure within another few years, these things will be a part of the course. And it will now see what happens. Normal CT and previously was not free. It was government of India had to pay, but after this 2016 agreement and all, now it's all free now. CTAC has got a full wing who is doing training now. CTAC has got a Pune has got a full fledged setup, and they are conducting the training. And all the private companies who are making EMR softwares are doing it. And for example, this Ayushman Bharat in Bihar and UP and all, they're just scanning and they're using the mobile. They don't even have anything in the medical health PHC and UHC. So they're just scanning in the mobile that doctors think. And with the OCR, these people are, these insurance companies are converting it and coding it and storing it. So by getting some 10 insurance policies, they will know which hospital is, which one is better, which one is good. So that's how the Hridyam, I'm saying, the sample scheme what Kerala is doing. They know which hospitals are good for so and so surgery. So they are directing. So thing has changed. It has come in that state where the value-based will give more and more important. Because Government of India projection is like if you implement like this, finally the cost cutting comes. How much I don't know, but the PwC report says if the preventive care, the importance is for the preventive care, and if you have the EMR, the data, you can prompt the patient like go and do this, and doctors can be prompted, and so they try to prevent adverse effect and do the thing. But for finally, what all it is, see to do all this, maybe investment is required, good storage is required. Actually, if I about my institute, if I say we got part of the e-delivery project, and we could also enhance our storage and systems because we also got a small grant from this WHO project of e-delivery. So they are doing that. For example, AIMS, all AIMS are under e-health. They have a portal and they have similar storage. So their informations are shared. They are registered in one name. The other AIMS will have the information. So slowly there are changes. It's happening. I'm also happy. Even I was not sure after reading the thing. Only I got confidence. So when Sir called me, I was having the right topic. I said I will do the session. That's how I selected the value-based healthcare. We have to bring the value to what the money we paid. So it should not be paying and getting the service. It is after service. It should be the reimbursement. So that only will bring down the cost of healthcare. That's what the Government of India says.
Okay, thank you, madam. That is so nice.
Yeah, ma'am. But in most of the private hospitals, it is not.
No, it is if you have the insurance card, they are doing the same thing. They may not be getting we will not be knowing. The bill will not be fully reimbursed. If they put a bill of 1,000 rupees, but the insurance company whom we have insured with, they will not be paying them fully. They will be some cases they will be at loss. Some bills they will pay. We are not knowing. No, we are just paying the premium and happily walking out. But the reimbursement side, they will not be getting the full amount. They are cutting. They will cut down. They're very, very, very strict. Ayushman Bharat is very strict. very difficult to get the full amount. They keep on questioning each one, like whether what is even the operation procedures are not clearly written. They are questioning and sending it back. Their way is to avoid, to reduce or cut down. That is the policy.
Yeah.
So if you use normal CT like terms, you won't make mistake. That is the major thing. And if the ICD coding is done, it will be no errors. The error reduction is the topic. Like any report, maximum automate. No need for human typing in. Of course, doctor's diagnosis he has to make. And that once he makes, whether medical records department or somebody can code it immediately. Need not be the doctor, or the software program can be made in such a manner that he selects through the browser and who puts the data. No, it is possible. It is they are running in. If you go to normal CT site, there are so many cases shown even in India in so many hospitals where it is fully implemented.
So that may be the reason why these hospitals are collecting some amount from the patient. No, even though we have the insurance, the difference between the company pays and their bill that we have to remit.
That definitely they will try to get the maximum of what they are spending. But this has brought down the unnecessary tests. They know that they will not get a reimbursement. They will immediately ask you are under which insurance, Star Health or which insurance, Reliance. So they will know how they are processing. So they will not make you do so many tests. They know that it will not get reimbursed.
Yeah, right. Thank you.
Yeah, that's all.
Okay. Yeah, any more questions? Yeah, Parvati?
Yes, sir. So I hope all the queries have been addressed. Now, I think it would be great if all of us got a virtual photo together. So I request all of you to please switch on your cameras.
Yeah, please.
What is that? What is that? Sir?
Sir is there.
Yeah, sir. Is that
So everyone please switch on your cameras. I can still see many of the cameras are off. Okay, I will take the photograph in 1, 2, 3 IEEE. Thank you. What else?
Thank you, Eldo, and yeah, please.
Okay, thank you, everyone. All the delegates, please note that the link for the feedback form of the session will be posted in the chat box. Please remember to fill the form.